must say I'd like to thank King's College and the Prostate Cancer Charity for the reception last night. Very nice. Glasses of wine, starting with slippery slope for some, I guess. But here we all are, bright and early. Yesterday we learnt a lot from our faculty, the clinicians, about the science behind the treatment of prostate cancer. And I guess today we're going to switch emphasis a little bit, certainly for the first part of the day. We're going to look at some of the psychological and sociological aspects of prostate cancer and its treatment. And I'd like to introduce our first speaker, Veronica Nanton, who's a research fellow at the medical school in Warwick. She's going to talk to us about prostate cancer in Afro-Caribbean men. Over to you, Veronica.
Good morning. As I think you probably know, the Prostate Cancer Charity has done a lot of work on awareness raising amongst men in general, but African and Caribbean men in particular. This morning I'm going to look at things slightly from the other end. I'm going to look at a study that investigated the experience of African and Caribbean men with prostate cancer. This was actually part of a wider study that looked at a range of issues, but I'm going to focus particularly on that. I'm going to start off by giving you a bit of background to put the study into context, then I'll talk about the findings, and then I'll try and pick out some of the issues which I think most relevant to practice. So I hope that sounds okay. It's going to be a little while before we actually get to prostate cancer, so I hope you bear with me while I go through a bit of background. Just to start off with now, for those of you who might not be so familiar with the geography of the region, I thought I'd use this map just to give you an idea of all the different islands and their relative size, but also of the big distance between them. Between, I can get this right, Jamaica in the north and Trinidad and Tobago just off the Venezuelan coast there's about just over 1,000 miles. So I think that's an important thing to remember, because it's very easy for people here to sort of lump people from the Caribbean together. Those of you who have connections with that region probably, I think you may agree with me, that this is something that tends to happen. But because of the distance, because of history, because of cultural factors, people from the islands are very, very different. And it's an important thing to recognise. People are very proud of where they come from. And then there's quite a lot of rivalry between different islands, and also differences between the large islands and the small islands. So it's just something to bear in mind, that people are not a homogeneous group. Not all the people that have come from the Caribbean are of black Caribbean origin, but of those who are, there are still many differences between them, although they do share the same roots from West Africa. Before we go on, I just got a couple of questions for you. It's only a really nice chance for me to use out the technology here, but I thought it would be an interesting thing to do. It's the first question. I'd just like you to sort of think about migration into Britain. And I wondered if you could tell me which of these dates sort of marks the start of the first wave of large-scale migration from the Caribbean to Britain. If you think it was 1930, could you press your number 1 on your buzzer, please? Number 2? 1948, number 3, 1955, or number 4, 1962. Well, that's interesting. I don't think that actually quite set up to 100%, does it? Yeah, the second answer was the correct one. It's actually 1948. Second question is, what percentage of the population currently describe themselves as black Caribbean? Is it 1%? That's number 1. Is it 3%? 5% or 10%? Can we have the answers? Yeah, again, it's actually 1%, which is quite a surprise. And the whole of the population that describe themselves as black is only 2% of the whole population of the country. The last question. Can you tell me which is the city with the highest concentration of a black population? Is it number 1, Cardiff, number 2, Birmingham, number 3, London, or Liverpool? The answers, please. Yes, most people got that one right. It is actually London. Out of the local authorities the 30 local authorities with the highest areas of concentration, only 5 of those are not in London. And I think Birmingham comes a close second. Right, that's great. Thank you. I told you it'd be a long time before we got to prostate cancer. Okay. Does anybody recognise this slide? Yeah? Anybody want to say what it is? Well, it's the SS Empire Windrush arriving in Britain in 1948, the date that sort of marks the start of the first phase of large-scale migration in the 20th century from the Caribbean to Britain. It's a sort of historic voyage, and I think it's a great picture. It shows these men sort of leaving home, coming to Britain, the motherland after the war, as economic migrants looking for work and hoping for a better future. And I use this picture because when we're talking about men with prostate cancer now, they are the Windrush generation. And I think, you know, not that the men on our study were on that boat, but they would have been coming over at the same time with the same hopes and aspirations, facing the same difficulties. And we can look back and think about sort of the long lives they've had here with all the problems that they will have faced. So it's a sort of nice sort of reminder of where these men have come from and the history that they've had. Okay. Why are we interested in prostate cancer in African Caribbean men in particular? Well, in the 90s, there had been some work done in America looking at the incidence between the black population and the white population, and it had been shown that there was an increased incidence in African American men. Now, over here, people began to anecdotally think that there was a difference between the experience of African Caribbean men and men from the indigenous population, but there had been no sort of serious work done until in 2003, Frank Chinicundo and his team published a small-scale epidemiological study that took place in northeast London, which actually gave the first proper indication that there was such a difference. Then a larger epidemiological study was carried out in Bristol by a group there and was actually only published in 2007 called the Process Study, which confirmed that the incidence amongst black Caribbean men in Britain was 3 times as great as that amongst white men. So what were the reasons for this? There's been a lot of investigation into the reasons for this difference. Some of the studies have concentrated on genetics, some have looked at lifestyle factors, environmental causes in particular, diet, and also people have investigated viral causes. One team has been doing some work tracing the route of the transatlantic slave trade, looking at the populations that originated in West Africa to see whether those differences are constant throughout those groups of people. In fact, there are variations, but we don't know, is that because of differences in diagnostic patterns, differences in recording, or are there actually true differences? I think on the whole, the main thoughts now are that there is some sort of interaction between genetic and environmental factors. So in 2006, the Prostate Cancer Charter for Equality Action Plan was published, and it pointed to a lack of representation of black men in studies. And this was particularly worrying in terms of clinical trials. So I'd been doing some work on prostate cancer, and I'd had the same experience. So I only had white, just probably white middle-class men in my sample. And we wanted to try and develop some strategies to engage wider groups of men in our studies. So we decided to use some different sort of recruitment methods to actually reach out into communities and get men from these populations to join in. So the aim of the study that we undertook, first of all, was to develop community-based recruitment strategies rather than going through hospitals and traditional sort of routes. We were going to go out in the community and see whether we could get people to join the studies through different methods. We wanted to look at the awareness side. We wanted to look at the understanding of prostate cancer and some concepts of cancer in general. But more specifically, what I'm going to eventually get to talk about is men's response to cancer and their experiences of services. So the first thing we did was to recruit interviewers who had a very good local knowledge. They were not academics, they were not trained researchers, but they had good communication skills, and they knew a way around the community, and they knew they could get people to talk to them. Some of them, a couple of them had been experienced as counsellors. And they recruited through what we call a snowball sampling strategy. This is a strategy that's often used in qualitative work where you're trying to look more in depth at people's experiences and understanding, whether you ask one person and you interview them and they sort of get you in touch with somebody else. And we also went through community groups. This has many strengths, this approach, because you do get an in-depth knowledge of these people's experience, but the findings are not very widely generalizable. If you're talking to people from one small area, the experience of somebody in another area might be very different. So you need really sometimes to move on from that to larger scale quantitative studies. But when we don't know much about an area, it's very useful to use this qualitative investigation to actually tell you the questions that you need to be asking. So the inclusion criteria for this study were just that the men had a diagnosis of prostate cancer and that they were first generation African Caribbean. The reason for that I'll come to a bit later. It's a small scale study, we only had 16 men. If you see, the age range was quite wide, from 50 years to 83 years. But the time they'd spent in the UK, they'd all been here, huge amount of time. And going back to that first slide, you can imagine these men sort of on that boat or similar boats all those years ago. Some of them as very young men, some of them already grown up. So a long experience, a long, hard life for most of them in Britain. The jobs they'd had were hard jobs in heavy industry, long hours. Some of them had been exposed to chemicals, and that was their sort of rationalisation for why they developed prostate cancer. They felt that they'd not been safe in their earlier employment. 11 of the men were married and 5 were widowed. And obviously being widowed, as I'm sure you know from your practice, has big implications for how you actually cope in illness of any kind, of prostate cancer, perhaps in particular. And there was a big range in the time since the men were diagnosed. Some had been diagnosed quite recently, others had been diagnosed many years ago and had some sort of recurrence. All the men were currently receiving treatment or follow-up. There were many comorbidities, all the usual ones that you would expect, but diabetes is particularly prevalent, as I'm sure you're aware, in African Caribbean men. Hypertension also, so this caused problems of management in many cases. Okay. We were interested in how these men came to be diagnosed, because at the time there was a feeling around that black men presented at a later stage. So we wanted to know what were the sort of decisions they made, what prompted them to go and seek medical attention. In fact, I think that idea has now been discarded. There doesn't seem to be any real evidence that men from this community present any later. But we looked at sort of what triggered them to go to the doctor, and in most cases it was they've been having urinary symptoms for about 3 months, and then they finally go to the GP. If they noticed any blood in their urine, then they went very quickly. Only one man went as a result of his PSA test, and he'd had that because there was prostate cancer in his family. Many of the men have been encouraged to go, or more or less dragged to go by their wives, so wives again were very important at that early stage. We asked the men how they responded to their diagnosis. I've asked this to other groups of men, and a lot of them had told me they'd been terribly alarmed and scared. But these men told us that they appeared very calm at receiving the diagnosis, and we asked them why this was. And the men put it down to faith. Faith in their medical practitioners and faith in God. And the idea was very much that the doctor would do his best for you, but ultimately the decisions about life and death were down to God. So they were quite sort of stoical in their response to their diagnosis. The experience of information that men had was not terribly good. Most of them had not had sort of things explained to them terribly well when they'd gone for treatment. And when we delved a bit deeper into that, we discovered that the men had been very reticent in asking questions. So consequently, there'd been a bit of a break in communication. They were not offered much information, and the men didn't ask. This was only true of the older men, the men that were 65 plus, which was most of the group. There were 3 who were younger. Now, this is why it's important to consider people's background, because if we think about these men, most of them have grown up in the West Indies, still during the colonial period. They would have gone to schools which were quite authoritarian. They would have been church schools or dame schools where you didn't ask questions. You listened, you wrote things down, and you only answered when you only spoke when the teacher asked you a question. They were not used to being proactive in question asking. So this set up a bit of a barrier from each side, because they were not being offered information, and the men in turn were not asking for it. The younger men, much more proactive in asking questions and much more involved in treatment decisions. Men were terribly appreciative of the radical treatments they'd had, and very sort of grateful for their experience, but they felt they hadn't really been very well prepared for the side effects of their treatment. Or maybe it had been explained to them, but perhaps not often enough, or they had not been told that the side effects were going to last for a long while, and that this had caused them some distress. Again, they hadn't asked the right questions. One advantage of using our community-based researchers was that they were very good at getting answers from the men which perhaps more usual sort of researchers would not have been able to get. They were able to probe the men, and eventually many of the men reported that they had had some insensitive treatment during their time in hospital, or after that they'd been treated a bit brusquely, they'd been made to feel embarrassed about urinary symptoms, and that they'd come across quite a bit of insensitivity. Men also expressed some confusion over the pathways of care, who was responsible. They seemed to be the last people in the loop between the GP and secondary care. And I don't think that experience is that unusual from other work that I've carried out, but it was certainly an issue for these men. On leaving hospital, men felt that they'd had little advice on managing their various problems. They hadn't been taught any exercises to help continence, and they felt that they'd been left to manage on their own. And the men with urinary problems, there had been a lot of delays in getting continence pads and getting practical help, and that had made life quite difficult for many of them. Sexual problems were reported by many of the men, and they'd had not a good experience of trying to get help with the sexual problems. Some of them had gone to either their GP or back to their consultant and had been sort of put off from asking for further help by the response they'd had. One man was told, oh, why do you want to bother with that? Why should you be bothering with that at your age? Another man was told, oh, so you want to be a macho man, which I think is a bit of stereotyping. And the man had said, no, I don't want to be a macho man, I just want to be me, which was quite a sad experience. There'd also been some problems in managing their various comorbidities. Again, the liaison between the different clinicians hadn't been that great. Men were confused as to whether their symptoms were related to their diabetes, for example, sexual problems, and the medication for hypertension had also made the urinary problems worse in some cases. As I mentioned earlier, the wives were absolutely key in helping the men manage their care. They were the information givers, the information retainers. They made appointments, made sure men got there, they looked after them, and they were extremely supportive, and the men were sort of full of praise for their wives, and really the ones that had them felt they couldn't manage without them. Families varied in the support that they gave the men. I think this is sometimes a sort of stereotype that people have, that people from minority communities look after their own, but many of these families are split up with different parts of the country. The care wasn't always there, relationships were not always good, so that wasn't necessarily the case. On the other hand, church and community groups were very important for these men. Only one of them belonged to a hospital-based prostate support association, but for many of them, the church would fill that gap, and they would go to see the church elders for support and counselling and for help with practical problems. Hardly any of the men had contact with social care agencies. Some of them had tried, but the services were either inappropriate or men had had difficulty in accessing them, because referral procedures were too complicated, especially for these old men. They'd sort of felt they'd gone from pillar to post and not really got anywhere, and in the end most of them had given up and preferred to manage on their own. Widowers, the 5 widowers were in a particularly difficult situation. They were very isolated. They really were relying just on the church and a few friends and neighbours to help them with their care, and this lack of contact with social care agencies really was very restrictive to them in terms of the support that they were getting. There is a particularly high proportion of lone families amongst older BME communities, so I think this is something that we may see more of, is older people from these communities living on their own. And in terms of any aspect of health, surely that's got to be a negative thing. We asked the men about their diets. We were interested to see, whether they had done anything since having prostate cancer to change their diet. And interestingly, most of them had. Many of them encouraged by their wives. They tended to eat a mixture of Caribbean food and English food, but many of them had cut down their red meat and were trying to eat more fruit and vegetables as a result. And they were aware of the relationship between diet and health. Most of the men used some forms of complementary therapy. Now, with the older men, these were herbs and leaves that they were used to from the Caribbean. People would use these things for sort of general health, and then there were specific ones that they used to help with their prostate cancer. And they sort of carried the memory of these sort of folk remedies sort of all their lives, and they were available locally, so people were still using these things. Only the younger men, the men that were teenagers or children when they came here, were not using those leaves. They were going to Holland and Barrett and buying whatever they found appropriate from there. But it was interesting that this was still very much part of the sort of self-management strategy of these men. Religion was very important to the men. Not all of them went to church, but they all had a very strong spiritual side, and this had supported them through life, through the harsh experiences of their life, and there was no reason that it wouldn't support them through, and it did really help. Not a fatalistic attitude, but a very stoical attitude to taking what came to them. I mentioned earlier that the younger men were more active in seeking information. They questioned more easily. They were involved in treatment decisions. The younger men had clearly been exposed to different sort of cultural influences. They'd been here for longer and had not had their education in the West Indies, and were more able, really, to get the best of what was available through being more sort of proactive. And this is an interesting point, I think, because, as I said in the beginning, it's a mistake to look at people from the Caribbean as a homogenous group. But we must also be aware that there's a second generation of men from African Caribbean backgrounds growing up now, and they're just becoming to the age where they're starting to be old enough to develop prostate cancer. And I think the experience of this group of men is going to be very, very different than the men that I've been talking about, because these men have what sociologists call mixed identities, or there's a concept of hybridity, that people have identities from their different sort of backgrounds, original background and the one they're living in, and they're able to sort of adopt the identity, not consciously, but they adopt the identity of the context that they're in. And this makes it easier to negotiate a society and to sort of manage. So I think that we'll see a very marked change in experience of this group of men. What will be very interesting from an epidemiological point of view will be to see whether there's a change in risk with this second generation, because that would support some of the sort of environmental ideas about contributory factors to the difference in risk between population groups. There's also an increase in the mixed ethnicity population. This is actually the fastest growing population group that there is. 3 out of 10 men of Black Caribbean origin live or are married to women from a different group, so this population is going to be increasing. What will their experience be? What will their risk be? In summary then, the needs that the men expressed were universal needs for care, good communication, sensitive treatment. But this was experienced through what you might call a cultural lens. These men had additional barriers to receiving that good care because of the communication, barriers to communication that there were. And you can see the influence of these cultural factors at all levels of information seeking. And I think also the assumptions of some of the healthcare professionals that they encountered had acted as a barrier to information and access to help, because there was an assumption if men didn't ask questions, then there wasn't a problem to be addressed. A high proportion of these men were living on their own, and they lacked what's referred to as social capital, that is, the means of accessing the resources of the society to improve their experience. And that, I think, is quite a major issue. Partners, as I've said, were extremely important, and the men who had partners, they were younger, they were part of the role. We see this in the rest of the population. Women manage health, it's what we do, and these women in particular made things a lot better for the men through getting them to seek treatment and keeping them on track with their care. Okay. I think the important thing when working with men from African Caribbean backgrounds is to look at the individual, look at the individual's experience, see what he's been through his life, what impacts on his present situation, and consider him in relation to the group that he comes from. The lack of questions from this group of men doesn't mean there isn't a need for information. And the lack of complaint doesn't mean that the men have no concerns. I think work with partners wherever possible. And importantly, if it's feasible, it's a really good idea to develop local knowledge, look at the resources in the community, see what can help, have a good idea of what's out there. So if men are not accessing usual sources of care and support, maybe we can facilitate putting men in touch with the resources that are out there. Also, it's a very good idea to link in with local churches and church elders anyway, and they are very often asked by men about prostate cancer and how to deal with some of their difficulties. So any information and training that they can be given has got to be a good idea. And I know it's not always easy, time doesn't allow for this sort of thing very, very much, but if it's at all possible, I think it would make a tremendous difference to the experience that these men have. Thank you very much.
Thank you very much, Veronica, for a very interesting insight into a different group from what we've been perhaps considering yesterday. Questions or comments from the floor?
I picked up my bags, but of course to ask me.
Any questions for Veronica? Yes, please.
Can I ask you, you said that, sorry, I'll see what it's found. You asked that some of the men had concerns about people being insensitive. Did people just attribute that to insensitivity, or actually did this group attribute that to their background in the sense that they felt people were being insensitive to their culture, the fact that they were African Caribbean? Do you think, did they attribute that to something that we could say it was because they were African Caribbean, or did they just see people as insensitive?
They just saw them as insensitive, yes. It was, we might interpret it as because of that, but that wasn't necessarily the case. It was just that they felt there was a general insensitivity. Men with hardly any comments were made, even though the men who were interviewing them were also black men. There were no comments. There were only 2 comments about racism came out. Talking about healthcare, I have to say, when they talked about their earlier lives and experience in the workplace, then men did talk about racism, but not within the context of healthcare.
Thank you. Can I just ask one more? Is that okay? I'm just interested, particularly in nursing, we're asked to be very culturally sensitive. And your advice, I suppose, particularly about how you manage that, the challenges for that, without actually following along stereotypes, really.
Yeah, I think that is a dilemma, because as I've been saying, you can't treat everybody the same, so you don't want to have a cultural stereotype. I think the thing to do is to be aware of men's background, but ask them. You know, if you're not sure where do they originate from, they may not be from Jamaica. Don't assume they're from Jamaica. But if you're not sure, if they sound a bit different, ask them. People will always be glad to tell you. And if there's something you don't know, people like talking about themselves and where they're from. You don't know about every culture, but be open. I think that's the best advice.
Veronica, it's a very interesting insight into the individuals that you talk to. From your experience, do you think you go so far as to say there's something we should be doing actively with the Afro-Caribbean population? Should we be doing something different to what we do for all of our patients?
No, I think the awareness raising that you're doing is really important, and that seems to be working very effectively. I think as a charity, I think you're doing a really good job out there. Perhaps the next stage will be to think about and develop some projects that can actually work with men who are having the experience of prostate cancer, as well as looking at awareness raising.
I think that point's incredibly well made, because awareness raising is what the Prostate Cancer Charity is about. We talked yesterday about 50% of men in this country don't even know what a PSA test is. So it's part and parcel of that same message. And what you're saying is continue with that, but don't try and focus or do something additional for this group, despite their unique needs. Thank you very much. Any other questions for Veronica? Oh yes, please, at the back. Tell us who you are.
From Barts.
From Barts. What's your name? You can always tell a man from Barts, can't you? You can't tell him anything, but...
Prostate cancer nurse of Barts, and just like a bit of information, really. We're starting a drop-in for Afro-Caribbean men in Yunnan very soon, and we're going to organize. I think it's a project of prostate cancer charities.
So this is a specific intervention that is being made. That's what I was interested in your view on. Thank you for that. Okay, shall we move on with the programme?